and substitute. We have Mr. Dinesh Pal, who is a senior nursing officer in the pediatric hematology and oncology unit at the Department of Pediatrics at PGICH. He will be telling us about how counseling these parent children who have this difficult illness. So, Siddharth, over to you for this session. I think we have received one response from that email was received and they were able to join through that email. So, rest of the people can please also let Manisha know if they have been receiving their emails or if anybody has been having any issues. Thank you. Over to you, Siddharth. Sorry.
Yeah, thank you, ma'am, for the introduction. I hope I'm audible and my slides are also visible.
Siddharth, you're audible, but your slides, they were visible briefly. Right now, they're not visible.
I'll just go back to this. Now?
Yes, they are all visible now and they're in full screen. Perfect.
Okay. So thank you, ma'am, for that introduction. And thank you, PHO chapter, for this opportunity. So I'm going to talk about an overview of immune thrombocytopenia in children for the nurses. So we will quickly take you through a case-based approach to immune thrombocytopenia, and I will tell you about how we define this condition, how we investigate for this condition, and how we treat this, and the advice that we will give for these children. So this picture here, I put it here because previously, when people said ITP, it used to mean immune thrombocytopenic purpura, as in we would expect children coming in with this red and blue spots on the body. But now we are calling it immune thrombocytopenia because we recognize that we might not always see children with these reddish and purplish spots on their body. So starting with a case, a typical case, a 6-year-old boy, Master K, was brought to the clinic with a sudden onset rash. And he was a previously well child with no significant family history, stable on vital examination. And on examination, there were only these petechiae, that is the skin bleeds, and one big ecchymosis on the left side. Ecchymosis again means skin bleed. There was no hepatosplenomegaly, and otherwise the systemic examination was normal in this child. So whenever we have such a child coming to our OPD or to the emergency, we ask ourselves as health professionals 3 questions. The first question is, are we dealing with a true systemic bleeding disorder? So if the answer to any of this is yes, then it's a bleeding disorder. If it is more than one set of bleeding, or it is a spontaneous without any trauma or disproportionate to the trauma that the child has had, a very deep bleed like a muscle or a joint bleed, or any bleed warranting the child to get admitted or transfuse blood, any family history, we have to keep in mind. And remember, whenever you see a child with bleeding, always be careful that this might be a non-accidental injury where the caregiver is actually injuring the child. So you look for any pattern bruises, like some instrument has been used to make the bruise on the child. So this is the first question we need to answer. The second we start thinking is, are we dealing with an inherited or an acquired defect? So usually when you have an inherited disorder like hemophilia and so on, then one would look at a more prolonged duration of illness, and there will not be any systemic sense. There will be only bleeding, and there might be even past history of bleeding or some procedure related bleeding. Often you will get a family history. But in an acquired defect, like what we are discussing today, like immune thrombocytopenia, the age of onset is usually later. In ITP, we usually see them in the preschool age, so 2 to 6 years. The short history of bleeding. And you might have systemic signs, especially if it is like a systemic disease like leukemia. But remember, ITP is an exception. There are no systemic signs. And you won't have any past history or family history of bleeding. The third question we see is it a primary or a secondary pathway defect? The ITP we are talking about today is a primary hemostatic pathway defect, where the platelets or bone marrow factor is involved. So in these disorders, predominantly bleeding will be from the skin or mucous membranes, and bleeding can even occur from minor cuts. There will be petechiae very commonly seen. You won't see any deep bleeds like muscle joint bleed, that is called hemarthrosis. And after trauma, the bleeding will be immediate. This is in comparison to deficiencies. So secondary pathways like hemophilia, where you will have bleeding occurring in muscles and joints, and you will not see petechiae very commonly. You might have very large ecchymosis, and it's common to see hemarthrosis, and often bleeding is delayed after trauma. And there is no need to like read this busy table. All you need to understand is that when you have a child with bleeding disorder, we usually do a platelet count, a prothrombin and APTT. And when you have an isolated thrombocytopenia with normal PT, APTT, and the child is otherwise well looking and everything is okay, then most likely this child is having immune thrombocytopenia. So coming back to the case that I started with, this is most likely true bleeding disorder because child has come with multiple skin bleeds without any other triggering factor. Likely this is a primary hemostatic pathway defect and likely acquired disorder. So most likely we're dealing with ITP. So these are the investigations. Like I told before, you can see the complete blood count shows only thrombocytopenia, HB, WBC is preserved. And if you see the peripheral smear again, it's all okay except for some giant platelets reported and the prothrombin and APTT are normal. So like I said before, this is most likely ITP. So now coming to the topic, this is the commonest cause of thrombocytopenia in children. And the peak incidence, like I told before, is in preschool toddlers, 2 to 5 years of age. And we say it is newly diagnosed immune thrombocytopenia up to 3 months from the diagnosis. Persistent if it is beyond 3 months up to 12 months from diagnosis, and chronic if we are going beyond a year from the diagnosis. The good news about this scary condition is that 3/4 or more than that children will recover within 1 year of diagnosing the condition. And though there is thrombocytopenia, which might often be severe numerically, seeing the platelet count, actual life-threatening bleeding like a hemorrhage in the brain or so on is quite rare. It will occur in less than 1% of the children. Now, why does this ITP occur? As the name suggests, this is an immune thrombocytopenia. Now, this happens because in our body, normally there is something called as a tolerance mechanism, wherein our immune system does not react against the cells of our own body. But sometimes after certain infections, like a viral infection or some stress, this tolerance mechanism is disrupted. And the body's own immune system starts producing antibodies and immune cells like lymphocytes against the body's own cells. So in ITP, what is happening is the platelet antigens are being recognized as foreign and the body is producing antibodies and lymphocytes against these platelets. That is what leads to platelet destruction, immune thrombocytopenia. In the majority of the patients, what happens is there will be a resolution. But in some patients, what happens is these immune active cells persist and lead to further severe thrombocytopenia and lead on to persistent or chronic ITP also. Now, to put it very simply, what I've spoken till now, if you have a previously well child with abrupt onset skin or mucosal bleeding, the examination is normal except for the bleeding. And if you do a complete blood count, which shows isolated low platelet count with maybe some anemia, which can be explained by the bleeding that the child has had, the peripheral smear is normal, then you can fairly be certain that you're dealing with a child with ITP. Next, we see how to confirm the diagnosis. So what is mandatory, like what is circled here, a CBC with a retic count and a peripheral blood smear with a blood group done is mandatory to diagnose and treat the child. The other investigations I'll talk about in the next slide, but this you need to keep in mind that CBC, retic count, peripheral smear is a bare minimum is mandatory for diagnosing. Now, all the other investigations that people talk about, like bone marrow, actually it is not a recommended investigation, but you should consider if there's any systemic symptoms, like the child is also having pallor, severe pallor or ongoing fever, or child is having lymphadenopathy, hepatosplenomegaly, multiple blood cell lines involved, like that. Other than thrombocytopenia, there is also neutropenia. So and so on. You would like definitely like to do a bone marrow to blood. Other diseases like say leukemia and aplastic anemia. H. pylori testing more done in adults, not so important in children, but maybe in the adolescent with poor response to treatment, you might consider. Immunoglobulin levels, again, one would think of doing when there is also history of recurrent infections or there is persistent or chronic ITP, because some rare immune disorders like common variable immunodeficiency can present as ITP. Direct Coombs test, particularly if there is anemia, because if there is DCT positivity, then it might be a combination of immune hemolytic anemia and thrombocytopenia, which occurs in a condition called Evans syndrome. Anti-platelet antibodies is not being done, as far as I know, in any center. It is more of like an academic knowledge, and the sensitivity and specificity is not 100%. Adolescent females and if then older ladies, if there is recurrent fetal loss and there are thrombotic symptoms, then you might do an APLA testing. ANA testing, again, we do if it is persistent or chronic ITP. So again, reiterating that other than CBC, peripheral smear, retic count, All these investigations are guided by the history and examination that you take in the patient. So if you are doing a thorough history and examination, you don't need to worry about diagnosing ITP. Nowadays, a lot of labs are giving this immature platelet fraction, and the high immature platelet fraction helps us to think of immune thrombocytopenia. But again, there are caveats and it is not really necessary. Just to quickly show you some examples, which is what is not ITP. Look at this child. This is a 5-year-old girl. Again, previously well child has come with ongoing fever and bleeding. And on examination, there is liver and spleen enlargement. And on the CBC, you can see that the WBC count is also low. The neutrophil count is also low. And the peripheral smear is showing huge atypical cells. This is a case of leukemia. So you have to remember that, again, reiterating that a good history examination in a CBC can pick up alternative diagnosis. So bone marrow confirmed acute leukemia here. Another child, 9-year-old boy, again, recent onset history of skin bleeding. But remember, the past history has also shown that there has been a significant bleed. This child was born to a consanguineous marriage. With all these red flag signs, and the peripheral smear also showed very large platelets. We went ahead and investigated. This was not ITP, this was Bernard-Soler syndrome, an inherited platelet defect. Another case, a 12-year-old girl, progressive weakness with no previous history. She also had pallor, which was a red flag sign, and the CBC showed pancytopenia. Multiple blood cell lines are involved. So again, retic count is low. So the bone marrow showed a empty marrow, hypercellular marrow. This was A+ again. So as long as you pick up the red flag signs, you can definitely be reassured that you can diagnose ITP easily. So in the history, you look for any systemic symptoms, bone pains, recurrent bleed, poor treatment response, consanguinity, family history. Examination, make sure there is no lymphadenopathy, hepatosplenomegaly, and the child is well looking otherwise. And laboratory wise, look for also disproportionate low HD, high MCV, abnormal WBC neutrophil count, and abnormal cells. So if you are ruled out all these red flags, we have arrived at a child with ITP. Now we'll quickly go into treatment. Okay. So now remember these two rules. When you have diagnosed a child with ITP, please treat the patient. Don't treat the numerical platelet count. It does not matter whether the child is having a 10,000 platelet count or a 30,000 platelet count or a 3,000. It is more important where is the child bleeding from and how sick the child is. Second is whatever treatment you are giving, you are not targeting some platelet count to the targeting that the bleed will stop and the child has a good quality of life. But having said these 2 points, there are also a lot of other factors which come into the picture. You have to see where the patient resides from, what is the socioeconomic status. You also have to see what is the daily routine. This might be a 10-year-old boy who is actively involved in some sports activity. And also what is the level of anxiety of the parents. And also, as I told you, where is the child bleeding from? And to an extent, how severe the platelet count is low, that also helps us in taking a decision. Now, there are published grading of severity. Now, if you look at this table, it is very tedious. I don't want you to read it and mug it up because nobody is going to sit and count 100 petaki in a patient. Okay. So, a more practical grading is published by the Canadian guidelines. So, this is more, we can relate to this better. So, children with no or mild bleeding in ITP, they will be having just, no bleeding at all. It will just be a platelet count low on the blood count. Or they might be having very mild epistaxis or skin bleeding, and this bleeding is not interfering with the daily activity. So here you can either observe the child or you can give them an option of treatment, which I'll talk about later. Moderate bleeding would be, there will be more severe skin manifestations or maybe some more troublesome bleeding like epistaxis or menorrhagia. Definitely we would treat these patients with steroids or IVIG. Finally, you have severe bleeding, like continuous epistaxis or intracranial hemorrhage, which is the most ominous bleed which can happen. And there you will have to even combine different models. You might give both steroids and IVIG, and you might even give platelet transfusion if there is a life-threatening bleed. So now let us see the treatment options that we saw in those tables. Now what is told to be the best modality to treat ITP is IVIG, intravenous immunoglobulin. So this is given at a dose of 0.8 to 1 gram per kg. We have commonly 5 gram and 10 gram vials available. So because we are all nursing professional, it is very important to understand how to administer these because this is going to be your responsibility. So usually pre-medication is not required in otherwise well child who has never received IVIG before. But if there is some concern that you are worried that the child might have a reaction or previous history is there of reaction, then you might give a dose of paracetamol and an IV Avil half an hour prior to giving the infusion. You have to ideally put the child on continuous vital monitoring, but if you don't have access to continuous vital monitoring, at least check baseline after half an hour, after 1 hour, and at least 1 to 2 hours during the infusion and post infusion. So once you have a 10, let us say you have a 10% IVIG vial with you, you should start at 0.5 ml per kg per hour for the first half an hour. Then you can increase to 1, 2, 3 every half an hour and go up to 4 ml per kg per hour for the remaining infusion. Please make sure, especially as nursing personnel, that the crash cart is ready in your ward before you start IVIG infusion. The laryngoscope, the adrenaline, ampoules, everything should be in place because you might have some common side effects like headache, cramps or fever, nausea, which is okay. You just need to slow the infusion or temporarily stop, treat the symptoms and proceed again. But in less than 1% cases, you might have serious side effects. This is after all a protein that you're infusing, so the patient can get the anaphylactic reaction. They can go into hypotension, bronchospasm, dyspnea, and then in that case, you have to stop the infusion, call the doctors immediately, keep the IV line patent and open, start fluid infusion, and you can give Avil hydrocortisone IV. And remember, when there is an anaphylactic reaction, the preferred way to give epinephrine is IM. So you have to give 0.01 ml per kg IM epinephrine if there is an anaphylactic reaction. Other rare side effects which can happen is aseptic meningitis and acute renal failure, but usually these are all reversible. So this is just to show you picture commonly available IVIG can have 5 gram and 10 gram, which we use in IT. Okay. Next, anti-D. I won't talk about this much. So 10 years back, we were using anti-D a lot, especially for patients who are having a positive blood group, not splenectomized, with a good hemoglobin. We used to give 50 to 75 microgram per kg as a slow IV push. But now there's a FDA black box warning that this can lead to severe hemolysis, which can manifest as fever, chills, dark urine, and respiratory distress in the child. So if you are giving, we have to observe for at least 8 hours after the injection. And if the patient has previous hemolysis, renal disorders, or some infection, then there is an increased risk. So previously, we were getting this 3000 microgram vial, which is no longer available. Now, this vial, which is commonly available on the right side, this is actually used in pregnancy. So this is not used in ITP because you can see the dose is 300 microgram and it is only for intramuscular use, not for IV use. So this we don't use in ITP. Now there are a lot of publications coming where you can, they are saying that you can even use IM anti-D for ITP, but as a standard of care, it is no longer being preferred. As I spoke to colleagues, they're also not using this very commonly nowadays. Now, after IVIG, the second commonest drug that we all use is glucocorticoids. So what are the options? You have oral prednisolone. You can give it at 1 to 2 mg per kg per day, going up to 80 mg per day maximum for a short span of 1 to 2 weeks. Or you can even give a higher dose, 4 mg per kg per day for 4 days and stop. You have to ensure that the patient is taking the prednisolone after food with some antacid, like say lansoprazole or pantoprazole or ranitidine. In severe cases, or the child is sick, not able to take orally, you might go for a methylprednisolone pulse, going at 30 mg per kg per day for 3 days. And that you can dilute the dose of 50 to 100 ml of normal saline or 5% excess and give over 30 to 60 minutes. Remember, this can lead to hyperglycemia and hypertension. So you have to check the BP and GRBS daily when you're giving methylprednisolone pulses. Other side effects to expect: gastritis, hypertension, weight gain, and if you're chronically using, cataract and glaucoma can also occur. But remember, the recommendation is that if you're using steroids in ITP, it has to be a very short course and it is not recommended to give beyond 2 weeks. Okay. Now, comparing these 3 drugs that I told for upfront modality, IVIG and anti-D work by blocking the FC receptor mediated uptake, whereas glucocorticoid has a more generalized approach to decreasing antibodies, phagocytosis, and improved platelet production. Response is highest with IVIG, but also fairly good with steroids. And the time to response is fastest with IVIG, occurring by 24 to 48 hours, whereas glucocorticoids need at least 2 to 3 days to kick in and start acting. IVIG obviously cost-wise is more challenging. Glucocorticoids are usually cheaper to administer when cost is a factor in deciding treatment. Now, coming back to the case, we counsel the child on the various options. As I told you before, in case 1, because he has come only with skin bleed, one option is to just wait and watch, because we know that 75% of the patients are going to recover. But this family was staying in a very remote village. We thought that they might not come back to us properly for follow-up. So we thought it's better to give some treatment to improve the platelet count. So we gave IVIG 20 grams And by 48 hours, the platelet count improved, we discharged, and when they came back to OPD, the platelet count further improved, showing the good response to IVIG treatment. So that, but please, I'm not trying to tell you that you have to give IVIG for all children with ITP. It is a balanced decision, like I told you before, which we have to take sitting with the family. Now, another case scenario, a 3-year-old girl, again, came with some skin bleeds in 2 days, but since today morning, she is drowsy, irritable, and vomiting. The complete blood count and results were consistent with, again, immune thrombocytopenia. But remember, when in a background of ITP, the child is having neurological symptoms, worsening sensorium, child is vomiting persistently, always think of IC bleed and get a neuroimaging done. So as you can see here, there was a big intracranial hemorrhage. So this is an emergency. This is very rare scenario. Again, we have to explain to the family that this IC bleed happening in ITP is very, very rare, less than 1%. And sometimes even if you treat the child, you remember that the treatment doesn't work in 1 hour, 2 hours. It might take time for the treatment to act, and the child may still end up having this IC bleed even after starting treatment. Various risk factors have been suggested, but not really proven, like head injury, very low platelet count, preceding other bleeding like hematuria, use of NSAIDs or underlying AV malformation, but there is really no proven risk factor. Once you have a child with IC bleed, you have to stabilize the vitals, airway, breathing, circulation, your ABC, and support the child. And this is an exceptional situation where we give platelet transfusions. Otherwise, in other bleeds in ITP, we prefer not to transfuse blood because there is no use. You know that there are circulating antibodies. Whatever platelets you transfuse, they're going to get destroyed. But in such severe life-threatening cases, yes, you can give some platelet transfusions. And we hit hard with combination of different modalities. We'll give steroid and IVIG. And if it is still not working within 3-4 days time, you might even want to do an emergency splenectomy to improve the platelet count urgently. We'll talk about splenectomy very soon. Another very useful drug, which we all should know about when treating ITP children, is tranexamic acid, which can be given 3 times a day at a dose of 15 to 20 mg per kg per dose. It's a 500 mg tablet. Epsilon aminocapric acid is also described. I have never used it personally. It is very useful when there is mucosal bleed like epistaxis, gum bleed, and menorrhagia. Another very useful thing is when these children come with gum bleeds from the oral cavity, what you can make them do is we can actually crush the tranexamic acid tablets, put some drops of water, make it into a paste, and apply where they are bleeding from the gums. Or they even make them to swish the tranexamic acid tablet dispersed in water in their mouth and then swallow it. So that will give a local effect to stop the bleeding. But remember one very, very important red rule. Do not give tranexamic acid if a child has hematuria, because tranexamic acid helps in making clots. And in the bladder, if the clots form, then it will lead to painful urinary retention. So in hematuria alone, never use tranexamic acid. Just to show you a picture, this tablet pause, very commonly used in children with bleeding disorder. And this is a tranexamic acid injection, which is also very commonly available. Now we move to the later part of the presentation where we talk about persistent or chronic ITP. So we saw that most children, 75 to 80% of patients with either just wakeful observation or with some treatment like IVIG steroid, they will recover and then they will be fine. But around 20% of the patients, they might go on to have persistent or chronic ITP. So they say that older children who come with a higher platelet count or no preceding infection, they might be more likely to develop this chronic ITP. But still, the good news for the parents is sometimes even after 1 year, even after 3 years, we do see children going into remission. So even if persistent or chronic ITP, if the child is well and not having a very significant bleeding, you can wait and watch and then manage the breakthrough bleeding just like we manage any other child with a newly diagnosed ITP. But if there is a recurrent troublesome bleeding, child is unable to attend school, the lifestyle is severely restricted, the child is not able to participate in any activities, then we can offer these various options, which I'll talk about now. Now, first, the thrombopoietin receptor agonist. We are all very excited about these drugs. In the last 5 years, the use has increased really phenomenally. So we have 2 drugs which are approved for children who are more than 1 year of age. That is L-thrombopan and romiplastin, particularly when they are more than 6 months of ITP, which is not responding to your standard IVIGs and steroids. We usually titrate the dose to achieve a platelet count of more than 50,000. And after achieving the maximum dose of these drugs, if there is no response in 4 weeks, then it is no use in continuing them. After we achieve 6 to 12 months of good platelet count, we can consider tapering and stopping the drug. Okay. No, L-Thrombopag is an oral medicine which actually binds to the thrombopoietin receptor and improves the thrombopoietin function. We give 25 mg once a day for 1 to 6 years of age and 50 mg once a day for more than 6 years of age. And we have to do 1 to 2 weekly platelet count and titrate. So if the count is less than 2000, you can keep increasing every week by 12.5 mg till you achieve maximum of 75 mg per day. And then based on the counts, you can titrate the dose like I've shown here. And the major problem with L-Thrombopag in children is the meals. You have to take it empty stomach. So 1 hour before or 2 hours after meals. And because it can bind iron, calcium, magnesium, you have to get 4-hour gap if the patient is taking other like this medicines, iron tablet or calcium medications or any supplements or dairy products that are rich in calcium. Then you have to keep a 4-hour gap with L-Thrombopag. So this makes it a little difficult in children. It can cause transaminitis. So you have to monitor SGOT, SGPT. And please remember, it's good to get viral markers done with L-Thrombopag because it can cause hepatic decompensation, chronic hepatitis C. Although there are theoretical concerns like it can cause eye cataract, glomerulofibrosis, studies have shown that this is not really very common. And it can cause iron deficiency because it's an iron chelator. So if you identify iron deficiency in CBC, we should supplement iron. There is also a theoretical concern that because it is increasing pitchform can lead to thrombosis. But that is usually seen only in patients of additional risk factors, like if they're immobilized for some reason, or in adolescent females who are taking oral contraceptive pills and so on. So this is just to show you a picture. Revolade was the original drug which came. Now we have so many companies making in India like Thrombopag and Thrombonet, L-Thrombopag. Next we move to Romiplastin. This is a parenteral drug. So compared to L-Thrombopag, which is an oral drug, this is a drug which has to be administered subcutaneously. So we started 1 mg per kg, go a maximum up to 10 mg per kg. Even though this is parenteral, because it's subcutaneous, just like insulin, the patient's parents or attendant can be taught by us to give it at home. So most of our patients, they are taking Romiplastin weekly at home only. So and again, we titrate the dose based on 1 to 2 weekly. If it is less than 50,000, we'll increase the dose. If we are achieving good dose, we will continue the same dose or reduce the dose and so on. Again, the common side effects, they will get some URI-like symptoms, throat pain, running nose and all that. Bone marrow fibrosis and thrombotic symptoms are more of theoretical concerns. It's well tolerated. This is just to show the picture of the injections which are available. We'll have to reconstitute and give it. Usually, it is not recommended that to use some drug, keep it in the fridge and again use it the next week for the patient. It is recommended as a once use and throw injection. So that's how we are supposed to use it. Sometimes what we do is we share the injection between 2 to 3 patients, or what we do is we round off the dose to the nearest vial strength that is available. Then coming to rituximab, this rituximab is given as a dose of 375 mg per meter square weekly for 4 doses. We can also, some centers have published good data with even low dose 100 mg weekly regimen. It is available as 500 mg and 100 mg liquid vials. So you have to dilute that to 1 to 4 mg per ml concentration in saline. Again, just like IVIG, you will start slowly 1 ml per kg per hour and increase every 1 hour by 1 ml per kg per hour till a maximum of 50 ml per hour. So similar to IVIG, routine pre-med is not needed, but if there is some concern, you can give paracetamol, Avil pre-med. Some centers even give a hydrocortisone dose before rituximab. Again, vital monitoring is same as IVIG, like I told before. Again, here rituximab, you have to keep crash cart ready. You have to be prepared to deal with anaphylaxis if it occurs or acute infusion reaction. So other than the acute infusion reaction, which can be managed similar to how you deal with IVIG reaction, there are other concerns that it can lead to immunodeficiency, hypogammaglobulinemia, reactivation of severe viral infections, and even other infections. You have to watch out for that. Other rare injury, which is rituximab-induced lung injury, which I have personally never seen in my practice. It's very rare. So this is again just pictures of rituximab injection, which are commonly available in the market. Finally, I'm coming to my last few slides. Splenectomy is a time-tested modality. People have always used when there is difficult to manage ITP, but now we are doing it less and less because of the availability of L-Thrombopag and Romiplastin. Whenever we do, we have to do laparoscopically. It's always good to make double sure that it is ITP and you're not missing some other diagnosis by doing other workup. And remember to vaccinate the children before splenectomy at least 2 weeks before for capsulated organisms, pneumococcus, HIV, and meningococcal. If you're unable to do that, it's an emergency procedure. At least make sure that by 2 weeks post-splenectomy, child will get the vaccines. And post-splenectomy, they have to be put on penicillin prophylaxis. 200 mg, sorry, I forgot to write penicillin there. Less than 2 years will get 200 mg, and more than this, 400 mg twice a day. And this has to continue up to 5 years post-surgery. And the main concern is this post-splenectomy sepsis. That's why I was reiterating, you have to ensure the vaccination and the penicillin prophylaxis after the splenectomy. There are also some concerns of thromboembolism, but again, many studies have shown that this risk of thromboembolism is not too great in the real world scenario. Now, again, quickly comparing these three modalities, thrombopoietin agonist, 60 to 70% response in 4 to 8 weeks of treatment. But the cost concern is there. But now with a lot of the generics being available, the cost is coming down. It is becoming more and more affordable for most of the patients. Rituximab, although it works well initially, the biggest problem is after many years, the response comes down. That is the big problem with rituximab. But this response is not sustained. Splenectomy, very good response, but now we are kind of preferring it less because of the availability of thrombopoietin receptor agonists. That tick doesn't mean I'm like, advocating for thrombopoietin agonists. I'm just saying that splenectomy is coming down because these drugs are available. Other drugs, dapsone, lot of us working in this large institutes, we like dapsone a lot because it's a very cheap drug, and up to 50 to 60% patients do respond to dapsone very well. But please remember, G6PD deficiency can lead to hemolysis in patients who are G6PD deficient. MMF, azathioprine, these are all drugs which can be used. There are a whole lot of other drugs which I really don't want to talk in detail about because they're all very anecdotal in experience. Coming to the last two slides, physical activity. This is a major problem in children. So it's so difficult to tell a mother or a father who's having a child with ITP that you should make sure your child doesn't get hurt. All of us who are parents know that it is so stupid when you hear, before I was a parent, I used to advise, now I feel I was so dumb telling a parent that please make sure your child doesn't get hurt. It's very difficult because the age group which is involved is a toddler age group. But still, we should encourage the parents that the child physical activity should be maintained. We can tell them what are the safe activities. So what is dangerous is contact sports. Contact sports is where there is a high risk will come in contact with another child while playing, like football, hockey, boxing, and so on. Even cricket, the concern is, the ball will come at full force and hit. There might be a risk of bleed. Whereas these are all very good for the child to do. Dancing, swimming, games played with a racket like badminton, tennis, where children are, standing apart and playing. Even cycling with a helmet and kneecap can be done. Okay, and the recent studies showed that in more than 100 children, the risk of injury was very less and only one patient actually required ITP-like treatment. So to encourage the parents to allow the child to have a normal activity, both at home and at school, we should avoid NSIDs. Very important, especially when they have fever or intercurrent illnesses. Avoid NSAID, use only paracetamol for fever and pain. And avoid all this Ayurveda, etc., where we don't know the unknown composition, especially when we are also giving our allopathic medicine because we don't know the interactions. And whenever these children go for any dental procedures, elective surgeries, or they have a trauma injury, they have to report to the hematologist so that we can make a plan for them. Keep the home safe. Simple things. Keep the knives away, scissors away. Pad your sharp edge furniture with some, cotton rags or pillows, and make sure the child sleeps between two people on the bed. Or if you're not able to, do that, at least if the child has to sleep alone, you can put the mattress on the floor rather than on the bed at a height. And if there are steps inside home, you can put gates for the steps. And oral hygiene has to be reiterated. They should brush twice a day with soft brushes and rinse them out, because poor oral hygiene lead to increased chance of oral and gum bleeds. And this is very important. First aid, when the child has epistaxis at home, you have to teach the parents to make the child tilt forward the head and pinch the soft part of the nose below the, just above the nostrils very firmly for 10 minutes. And we should avoid keeping on removing the fingers and checking if the blood bleeding is so full 10 minutes without removing pressure. We have to continue. This works very well. And vaccination, routine vaccine should continue. We can use ice pack at the area for 5 minutes before injection and, use a subcutaneous route wherever possible. But if you have to give IM vaccine, use the small the gauge so that you can avoid hematomas. And after injection also, you have to give 10 minutes continued pressure. MMR vaccine, lot of, people feel wrongly that the MMR vaccine should be avoided because it leads to ITP. But remember, ITP is a very rare complication of MMR vaccine. On one hand, even if the child gets ITP, there is hardly any chance that the child is going to have a serious complication. But on the other hand, if we don't give MMR, there is 90 to 95% chance the child is going to end up with a life-threatening infection. So we have to reiterate that MMR vaccine should be given as per the schedule. And live vaccines, the problem is if they get IVIG rituximab, you have to delay the live vaccines because these will lead to immunosuppression. So you have to postpone the live vaccines. And also, if the patient has got a very high dose of steroids for 2 weeks or more, we might have to wait for a month before giving the live vaccine. So finally, I conclude with these take-home messages that remember, when you have a well child, sudden onset skin and mucosal bleeds, your CBC is showing only low platelet count normals here, most likely you're dealing with an ITP child. If this child has only skin bleed, you can just wait and watch regularly seeing them in OPD. But if there is significant bleeding, you can use IVIG or steroids. If there is an intracranial bleed, you can use multiple approaches and you can even transfuse platelets. And if there is persistent chronic ITP, make sure you do workup for secondary disorders and thrombopoietin receptor agonists like eltrombopag and romiplasm, rituximab, splenectomy, other options. We have to weigh the pros and cons based on the particular patient scenario and take a call. Thank you very much once again.
Thank you, Dr. Siddharth, for such a comprehensive overview of ITP. You've covered almost A to Z everything, and it was very informative. Now I request Dr. Dinesh to Mr. Dinesh to take over and talk his perspectives, nursing perspectives on ITP. He had he did a very good job on nursing perspectives in hemophilia earlier in one of these sessions. We are ready to listen to you, Mr. Dinesh. Please take over, and we'll have the questions at the end. I request you to wind off in 15 minutes so that we can have the last 5 minutes for the question and answers. Over to Mr. Dinesh. So request all the participants, please post your questions on the group in the chat box so that if there are any queries, you can take up at the end. Mr. Dinesh?
I think he's here and he tried to join, but let us wait for a minute.
Yeah.
1 minute. Yeah, I am sharing.
Yeah, sure.
So in the meantime, Siddharth, right, I'll echo what Dharani said, wonderful and comprehensive overview. There is one query for you in the chat box about how to prepare injection romiplastin. And indeed, this was a query I also had. You mentioned something about advising people to prepare it at home.
Yeah.
So that's a novel thing because it has a slightly difficult dilution, etc. So I think
that is true.
Before Dinesh starts his talk, or would you like to answer it later?
No, I'll just quickly answer it. Basically, the 125 microgram vial, we will add around 0.4 ml of sterile water. And the 250 microgram vial, we add around 0.7 ml of sterile water. So like some patients where the parents are very, educated and they're very confident, a few times with the nurse here, we make them give in front of our eyes because these are usually chronic ITP patients who are going to require weekly for many, many weeks. So then they learn and they give it, but their parents will have to be very educated and they'll have to show it in front of us. Then only we can trust them to give it.
Right. Thank you. So I think further questions we'll take up at the end. Please, Mr. Dinesh, please start your talk. Thank you.
Thank you, ma'am. First of all, I would like to I am audible. Am I audible?
Yes. You are audible. Your slides are visible perfectly. Please
Thank you,
start.
ma'am. Yeah. First of all, I would like to thank organizer to provide such opportunity. Basically, today we are going to discuss about the counseling of parents, patient, and we are also going to discuss some key points regarding nursing care in ITPs. So the ITP patient may experience a range of emotions that can differ according to the disease course and the stage of life. These emotions can be the result of the disease itself because of the in treatment they are taking or a part of coping with the disease. The 20 to 20% of the children who develop chronic ITP may struggle with the burden of disease and side effects of treatment. Children tend to be more concerned about their appearance and restrictions on their lifestyle. Some ITP treatments can cause significant weight gain, which can lead to depression in many patients. Children can also feel isolated by not being able to take part in everyday activities with their friends. ITP is associated with fear and anxiety also about uncontrolled bleeding and long-term consequences of treatments such as splenectomy. The symptoms of ITP can have significant impact on a patient quality of life and can affect the work productivity. Providing appropriate support and counseling is essential to help patients and their families cope with ITP. So, first one, all of the counseling should be done in the language which patient understands, and correct medical information regarding disease must be provided uh, to the patient and the parents. We should clear all doubts of the patient and parents. Uh, all this is knowledge part already covered by the Dr. Siddharth, but we will revise once again for the normal. This is for the patient. What is ITP? So the word in ITP is basically also known as immune thrombocytopenia and autoimmune thrombocytopenia. Purpura is defined and isolated thrombocytopenia with normal bone marrow and is absence of their cause of thrombocytopenia. Thrombocytopenia means less platelets. Purpura means red spots on the body, not necessary in ITP. So next question the patient asked to us ki what where are the platelet forms? This is we all knows bone marrow produces three kind of blood cells: white blood cell, platelet, and uh, red blood cells. What is thrombocytopenia? Basically, the platelet normal platelet counts is 1.5 to 4 lakhs, but uh, platelet count is between 1 lakh to 1.5 lakh is not significant. Any platelet count less than 1 lakh is significant thrombocytopenia. So what happens in thrombocytopenia? We all know platelet are blood cells that form blood clots to help stop bleeding. Blood cannot clot normally in thrombocytopenia because of reduced platelets. This cause bleeding. And the causes of thrombocytopenia is basically we can say the increased destruction of platelets or the decreased production of the platelets. What happens in the ITP? In ITP, red bone marrow produces normal platelets, but platelets get destroyed in the blood because of the autoimmune response of the body. So what is the causes of thrombocytopenia? In normal thrombocytopenia, we can say B12 folic acid deficiency, bone marrow failure, B12 folic acid deficiency, bone marrow failures, cancer, leukemia, aplastic anemia, and etc. But the platelet destruction, which is mainly found in the ITP caused by the autoimmune disease, infections, etc. Types of ITP. Basically, we can classify it in the primary ITP or secondary ITP. Primary ITP platelet count is less than 1 lakh in absence of other disorder. Secondary ITP is caused by infection, autoimmune condition, primary immunodefensive disorder, drugs, etc. We can also classify it into the newly diagnosed uh, acute thrombocytopenia. Newly diagnosed cases to 3 months, persistent ITP lasting 3 to 12 months, and chronic ITP beyond 12 months. So, how do children with how can we identify the child with of ITP? Symptoms and sign symptoms. For parents and the healthcare workers, recognizing the sign and symptoms of ITP is crucial. Then when we will see the skin of a child, we can found the patches, the purpura, and the douches. Patches is a small red or purple spot on skin. These occur when tiny blood vessels beneath the skin break, and they are particularly common on legs. And we can see the bruising, one of the hallmark sign of the ITP in children, in unexplained bruising with or without trauma. And oral care, we can found bleeding, oral bleeding, gum bleeding, nose in nose epistaxis. Rarely hematuria, blood in stools and vomiting, subconjunctival bleeding, heavy menses bleeding in the adolescent girls, bleeding in brain, lungs, etc. With mucosal bleeding, oral bleeding, and nose bleeding, tongue bite by spoon, lollipop, bleeding may occur by this. And how can we diagnose the thrombocytopenia? Normal HbW WBC count is normal, but no features of lymphadenopathy, hepatosplenomegaly. Sometimes a bone marrow test is advised to rule out, but not for ITP. It will cause to find out the other causes of thrombocytopenia. How the ITP is treated? Treat on treat only when platelet count is less than 20,000 or patient has mucus bleeding. If the patient is having platelet count less than 20,000 and mucosal bleeding is absent, there is no need to treat ITP. Options for treatment is IVIG, prednisolone, IV NTD. Treatment of ITP is explained by my previous speaker. So general instructions to parents. Basically, we have to counsel the patient, please do not panic. If the platelet count is usually very low, less than 10,000 in the ITP cases, but it will improve after 1 to 2 weeks usually. Most children improve within 6 months and do not need any long-term treatment. Risk of life-threatening bleeding is very low. And we should also counsel the patient to avoid the traumas. Traumas means care while traveling in vehicles. We should not, the patient or parents should not travel by the motorcycles. And if they are doing travel with bicycle, they should wear the helmet. And otherwise, we should counsel they can use car or auto or bus. Avoid IM injections to prevent hematoma. Nose picking is we should also avoid. Also counsel the patient don't use the child should not use earbuds, avoid constipations. And we also advise to avoid NSAIDs like Brufen, Meftal, etc. and anti-platelet drugs. Now, general instructions for nurses, what we should follow when the patient come to us, counsel patients well, how to prevent bleeding. Bed drilling, always put the bed drilling up when the patient on the bed. Patient should not fall in the hospital from the bed, as well as patient should not fall at home also. Be careful while inserting cannula and in the chubby children, because patient are on the patient may be on the prednisolone steroids, so patient are chubby. So cannulation is a very difficult task. So always cannulation should be done by the senior or experienced nurses. And hygiene of the patient is very important. The patient should do the brushing daily. Do not, and there is no need to follow platelet counts daily. Improvement in bleeding will happen before platelet counts improve. General instructions to nurses again: fever, no NSAID to be given to the patient, only paracetamol we can give. Monitor BP during hospital admission. Some patients are on steroid and IVIG. No other treatment is advisable. Goat milk, papaya milk, curcumin, kiwi fruits should not advise to the patient. Some of the patient come to us and ask to us, can papaya leaves help increase platelet count? We said no, it is not recommended for ITP patients. Will any food improve platelet count? No. Basically, no. In ITP there is no rule to improve the platelet count. We should advise to ensure normal balanced diet to the patient for the normal growth of the patient. We should advise fiber-rich food for so no role of any special food in ITP. ITP is not a deficiency disease. Fiber-rich food we should avoid for constipation. What to do in bleeding? Important, the patient came to us with a nose bleeding most of the time. So it is a very frightening condition for the parents, patient, relatives also. So patient comes to us, or we should teach the parents, we should counsel the patient when the child has nosebleed, don't panic. Digital compression of the lower third of the nose, most of the time we can, the bleeding will stop after a 10 to 15 minutes compression. This is called tortoise maneuver. Child should be sitting up with the head in the comfortable position on parent's lap. Tilt head forward slightly. Apply continuous pressure on the anterior portion of the nose with thumb and forefinger for 10 minutes. Child should breathe through the mouth and allow any blood to run into a kidney dish rather than swallowing. If the child and the nurses and the parents should not take tension that child is crying. If the patient is crying, they can take breathe from the mouth. Usually bleeding stops with compression alone, even in severe thrombocytopenia. So we can apply saline nasal drops. We can also administer saline plus tranexamic acid drops, mix and still. Bottle-clot nasal drops often advised by ENT doctors. If severe, then nasal packing by ENT doctors may be done. In gum bleeding, bleeding from tooth socket, etc., we can use tranexamic acid. We use in our hospital also crush. The tranexamic acid comes in the tablet form. Crush and apply as a paste to the bleeding site. Repeat it once in 4 to 6 hours. Can swallow the paste? Not. Some of the patient ask to us ki my child swallow the paste, so what to do? So there is the swallowing the paste is not harmful. Injection tranexamic acid can be soaked in gauze and applied. For bleeding, we can use tranexamic acid soaked, or we can use Adlin also. Adlin soaked gauze can be applied as a local application, and ice cold water taken mouth and spit after few minutes. Local agents advised by dental surgeons can be used. Oral hygiene is very important. Patient and parents are often afraid to brush, thinking bleeding will increase. Counsel them that oral hygiene is very important, as poor hygiene leads to gingivitis, and gingivitis leads to bleeding. So use toothbrush with soft bristles. Encourage mouthwash. Use toothbrush with soft bristles, but do brush daily. We can encourage the mouthwash also. And for nursing parts, basically for the nursing interventions while administering IVIG. IVIG must always should be given as an infusion, starting with 0.5 to 1 ml per hour, and then increasing dose as per charted. Allergic reactions, fever, itching, difficulty in breathing should be monitored. If this type of any activity occurs, stop infusion. Crash cart should be ready. Inform duty doctor. Headache check. If the patient is in the case of prednisolone, methyl prednisolone, BP to be checked every 6th hourly while in hospital. BP to be checked at visit during OPD visits. Encourage normal diet. Weight in the when the patient is taking steroid, weight gain is expected. So counsel the patient. There is no need to worry. Behavioral issue may be ho sakte hain. It may be irritability, anger also. So we should counsel the patients. IV anti-D injections. Always check if it is for IV use. Do not use Rogam. Rogam basically it is a brand which is given IM in the pregnant ladies, and we should never use. We should never use IV NTD given a short IV infusion. In previous yearly we used. Nowadays we are not using NTD. Check urine color because it causes hemolysis. So always check the urine color. Hydration. We should maintain the hydration of the patient to prevent the drainage of kidney functions. Dapsone, it's very normal drug advising patient with persistent or chronic ITP given as loose tablet from pharmacy, usually not safe in G6PD deficient patients. So G6PD screening always done before starting medicines. Watch for black urine, paler skin rash. Altromopag advising patient with persistent or chronic ITPs, but we should very clear. All the nurses must be clear, and patient is also counseled that it should be taken 2 hours before or 4 hours after antacids. Calcium syrups or tablets, multivitamin containing minerals like selenium and zinc, milk, juices, etc. Romiplastin, it is given as subcutaneous. Carefully while application, apply pressure for 2 to 3 minutes after injection. Can apply ice compress for 1 minute if needed to reduce bleeding. Rituximab used less frequently, given like IVIG. Pre-medications also, or pre-medication always used. Continuous monitoring needed. Crash cart to be kept ready for any reaction. Splenectomy very rarely advised now. If advised, vaccination prior to splenectomy are to be given. Hemophilus influenza, pneumococcus, and meningococcus vaccination should be done. Most splenectomy risk of infection high. Parents should take child to nearest hospital when there is fever. Oral medication penicillin given for 5 years after surgery. Counseling for long-term care. Patient will have to come to hospital repeatedly in persistent and chronic ITP. Regularly visit is very important. We should counsel that they should come on time for regular visits. Don't worry about platelets count given by a machine. Manual platelet count is important. Sometimes it takes months to year before count normalize. Do not panic if new bleeding happens. Give as normal a life as possible for child. Can go to school normally, avoid trauma, heavy school box, sports, skating, can do swimming and indoor sports, cycling with trainer, wheels and helmet, avoid sharp objects, sharp pencil, seizure, etc. If headache or if history of trauma, take to hospital immediately. Uh, Before going on conclusion, I want to show some more slide to so emotional support. Emotional support. Acknowledge the emotional impact of having a child diagnosed with a chronic condition. Validate parents' feeling of worry, fear, guilt. Encourage open communication about emotions and concerns. Provide a safe space for parents to express their feelings without judgment. Teach coping mechanism for managing stress and anxiety. The coping mechanism for managing stress and anxiety for parents, it may be a play and child for walk and etc. This could include relaxation technique, mindfulness exercises, or seeking social support. Offer practical tips for managing daily life with a child with ITP, such as organizing medication, creating a support network, and maintaining a healthy lifestyle. Basically, therapy for adults, for parents के लिए they can time management, nature, yoga, meditation, hobby, etc. They can use. For the child's cook a meal, essential oils, take a walk, get enough sleep, spend with friends, eat healthy food, take a nap, and many we can do for these techniques. Empower parents to become advocates for their children healthcare needs. Encourage them to ask questions, seek around opinion if needed, and actively participate in treatment decisions. Provide resources for navigating the healthcare system, assessing support services, and understanding insurance coverage. Community resources. Connect parents with support groups or online community where they can interact with others, family facing similar changes. Provide information about local resources such as pediatric hematologist. It is a very important fact to provide information about local resources such as the pediatric hematologist, support organizations, or educational workshops. Explain the diagnosis and treatment of ITP in language that is suitable for the child's age. If a child is 11-year age, we can tell about the disease as per 11-year age and the level of understanding. Use visual aids or storytelling to make complex medical concepts more accessible. Validate the child feelings. Emotional support is very important for the child. Validate the child feeling and concerned about their condition. Encourage them to express their emotion and ask questions. Foster a sense of resilience and self-efficacy by the highlighting their strengths and coping abilities. Peer support. Facilitating opportunity for the child to connect with other children with ITP, either in person or through online forums. Peer support can help reduce feeling of isolation and promote a sense of belongings. Encourage age-appropriate independence in managing aspects of their condition, such as taking medication or recognizing symptoms of bleeding. Provide praise and positive reinforcements for their effort in self-care. Normalizations. Emphasize that having ITP does not define the child and that they can still participate in activities they enjoy with safety measures, encouraging a sense of normalcy in their daily life as much as possible. With safety measure means don't use knives, but while cycling, they should use helmets. They should for the child safety measure, while sleeping, they can sleep at home on.
Dineshi, are you about to wind up? Because
Yeah,
so that you can take, can you please wind up in the next minute or two
yeah,
so that
yeah, yeah,
we pick up a
yeah,
couple of questions?
yeah, yeah, yeah. Hmm. So conclusion. The conclusion for the day: need long-term care in few patients. Counseling for parents is very important. Nurse should have correct knowledge so that they can counsel properly. Thank you.
So thank you very much. That was an excellent overview, and I think you touched upon a few very pertinent points, which practically every parent and a lot of medical professionals are very confused about. So almost all children who have ITP have been treated with some kiwi juice, some goat's milk, some papaya, some people ka patta, or something or the other. And I think this is a problem pan India. So Mr. Dinesh has addressed that point very much in detail and very clearly that normal diet is to be given. No, there is. So we tell our patients that there is no role of any juice, any like goat's milk, any camel milk, any other weird milk, any people or papite ke patte ka arak, any kiwi fruit, anar, angur. Because these are all expensive things and they are not of any proven benefit. Some of them may even harm patients. In fact, once we had a child who developed infection known as brucella because he took some goat's milk for ITP. So these are all things to be avoided. And the other very pertinent point that Mr. Dinesh raised was that please tell patients that they should be using helmets if they are riding cycles and scooters. Smaller helmets are very easily available for children at all sports shops. So whenever they buy a cycle, a helmet would be available as well. So that should be advised so that children don't fall and have an intracranial hemorrhage. I think let me just look at the chat box. So Dr. Siddharth has answered the question on dissolution of romiplastin in detail. Please do ask any queries if you have here, and or you can speak up in the group for any questions at all to either Mr. Dinesh or to Dr. Siddharth. So one very important thing is that of all the drugs available at this point, steroids are considered to be the drug of choice because of the ease of availability, ease of giving, and their cost. So of the multiple drugs available to us, including IVIG, at this point, most of us prefer to use steroids as a first-line agent. However, like Dr. Siddharth mentioned, steroids and IVIG are both very good first-line agents to have. And the other agents, which Mr. Dinesh as well as Dr. Siddharth has mentioned, they are used for chronic ITP. Majority of the children recover without any treatment whatsoever. So I'll just wait for a couple of minutes if there are any further questions on the chat box. Otherwise, a link has been put in the meeting group, chat group. So please do share feedback for this session and let us know on the feedback form, and please also let us know if the email was received on time by in the email by people. The link for joining, I mean.
I think Dr. Richa, if participant can speak up about this, that they haven't received any mail or anything, I think it
I've
would be easier.
requested them in front of you. You're also there.
Yes, yes, yes.
Please ask them again, or please drop them individual
Yes.
emails to people who are here, so that they can let us know. I think this has happened a couple of. So I think we have quite overshot our time and there don't seem to be any further questions. So I thank everybody for attending this session. Thank you, Mr. Dinesh. Thank you, Dr. Siddharth, for excellent sessions and wonderful learning. So bye, everybody.
Thank you. Thank you.
Thank you. Bye.
Thank you.
I request all the participants to just fill up the feedback form, and then you can leave the session. Thank you, everyone.